Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Haley Eckel, a PGY3 anesthesiology resident at the University of Saskatchewan in Saskatoon, discusses burnout, wellness, and workplace needs in the specialty of anesthesiology. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
The title of my talk is The New Balance, so navigating burnout, wellness, and workplace needs. And so the learning objectives for this session is I'm hoping by the end of the session, everybody will be able to understand some of the recent trends in burnout among anesthesiologists as well as trainees, identify risk factors for burnout unique to our specialty of anesthesia, compare and contrast some of the wellness initiatives that have been implemented to combat burnout amongst both attending physicians and trainees. And then we'll focus a little bit on some of the initiatives that have been implemented here at the U of S, and then describe some of the challenges institutions face in balancing wellness initiatives with residency training requirements. So I wanted to talk a little bit first about what exactly burnout actually is. I think it's something we hear tossed around a lot, and I think we all have a kind of sense of what it is. But there is actually a definition about it and a definition of it. And I think it's important to actually understand what that definition is so we can be really clear about what exactly we're actually talking about. So the term burnout syndrome actually first appeared in the literature in the mid-1970s in an article by psychologist Herbert Freudenberger in the Journal of Social Science. And burnout syndrome is defined by the World Health Organization as a syndrome resulting from chronic workplace stress that has been unsuccessfully managed. And it actually was added to the 11th revision of the ICD-11 as an occupational phenomenon. So broadly speaking, burnout syndrome is accepted to consist of three factors, and those are high emotional exhaustion, high depersonalization, and low personal accomplishment. And I think something that's really noteworthy, or at least was noteworthy when I was going through some of the literature, is that the WHO really emphasizes that burnout refers specifically to phenomena in the occupational context and should not be applied to describe experiences in other areas of life, which I think really highlights that burnout is caused primarily by the workplace and not actually the individual. So when we look at people who are at high risk for burnout versus actual burnout syndrome, the really big difference is whether the presence of a low sense of personal accomplishment is there. And so people at high risk for burnout are going to have emotional exhaustion and depersonalization, but they aren't yet at that point where they have the low sense of personal accomplishment. And when we see kind of that trifecta of those three things, that's where we see people experiencing actual burnout syndrome. So some of the symptoms of burnout syndrome are things like memory difficulty, decreased concentration, insomnia, irritability, and emotional exhaustion. And I think these symptoms can be kind of easy to recognize for, outsiders or people who are interacting with these people who are maybe burned out, or even for the person experiencing burnout. I think it's easy to be like, oh, I'm having memory difficulties, I'm having decreased concentration, all of these symptoms. But I think it's often difficult to really quantify or measure these things. And so I wanted to talk a little bit about how we actually do that. There are a number of scales available. I think the most common one is this Maslach burnout inventory, so this MBI, and it assesses the three components of the classic burnout triad that we just talked about. It's been used for a while to look at burnout in different specialties, but it was actually only validated in 2015 for use in anesthesiologists. And so this is just an example of the MBI, or one kind of form of it. And so section A in the top left examines burnout or emotional exhaustion. Section B looks at depersonalization, and that's in the bottom left of the screen there. And section C looks at personal achievement. So as we would expect, someone with high risk of burnout would score really high in both section A and B. And then someone with burnout syndrome would again score really high in section A and B, but score lower in section C, which is looking at that personal accomplishment. So I wanted to talk a little bit about the pathophysiology of burnout. I think we often think of these things as just kind of a mental wellness issue, but I think there is actually some physiological basis for burnout syndrome as well that we should touch on. And so we know that exposure to chronic stress plays a role in the development of burnout as well as depression. And so it results in exaggerated activation of the HPA axis and the sympathetic nervous system. So when we talk about the hypothalamic pituitary adrenal axis, it's the primary means through which the stress response is mediated, and chronic prolonged exposure to stress can lead to dysfunction of this axis. And that's primarily through loss of the negative feedback loop. Something I thought was interesting and something I came across when I was preparing this presentation was that the toll of chronic stress is often termed the allostatic load. And so this can actually be quantified by looking at downstream effects of stress. So things like cortisol levels, catecholamine levels, your systolic blood pressure, heart rate variability, just to name a few. But what was even more interesting to me was that there's actually no clear link between burnout syndrome and the allostatic load in patients that have been diagnosed formally with burnout syndrome. And so I think we have this idea that there is some link, but we haven't yet necessarily figured out exactly what that link is. That said, there are some physiological markers that have been positively correlated with burnout, and those are things like an increased A1C, increased CRP, increased cholesterol, increased white blood cell count, just to, again, name a few. That said, none of these markers are all that sensitive or specific for burnout syndrome. I think we can all think of a whole host of illnesses or diseases where we'd see some of these things. And so I think the likely scenario is that an individual's response to stress is probably influenced by a combination of environmental and genetic factors. And I think we see that kind of in a number of different presentations medically, a number of different diseases, that there is both that environmental and genetic portion. So I think anytime we talk about wellness, I think we always get, a few people that kind of question, why does any of this matter? Why do we need to talk about these things? And I think that's a really valid question. I think wellness is something that's really, I don't want to say harped on, but I think in our society, it's really come to the forefront. And so I think, questioning why we're spending so much time on this is not unreasonable. But we know that burnout is linked to poorer physician quality of life, with links to depression, suicidal ideation, substance use, which is obviously something that I think we're all very aware of in the specialty of anesthesia, lower workplace satisfaction, and disrupted personal relationships. And so there is likely a link between burnout and other mental health disorders like depression and anxiety. I think it's important to note that it can be really difficult to differentiate between burnout and depression in physicians. Burnout itself is a risk factor for developing depression, and there are multiple studies that relate depression to similar health outcomes that are seen in burnout, such as substance abuse, heart disease, and somatic symptoms. But depression can often be a really confounding factor in determining the link between the two. And so I think when we see things like the physician suicide rate, which is higher than the general population, and we see approximately 300 to 400 physicians commit suicide each year, we can't necessarily pin that directly on burnout. But I think given that there's a link between depression and burnout, I think addressing burnout is really important. I think for resident physicians, of which I am one, obviously, I think the stakes are even higher, given that suicide is the second leading cause of death behind only neoplastic disease. And so I think at the individual level, talking about burnout, addressing any of the possible risk factors for burnout or any of the possible causes we can, I think is really important and worthwhile. So this is a nice little table I found in one of the articles I was reading. And I think when we look not just at the individual level for why talking about burnout is important, but also more at a systems level, there's a number of research articles that show that burnout is highly associated with the intention to leave medical practice. And anesthesia, I think you can see us down there in the bottom right corner, actually has the highest reported rate of intention to leave at 46.8%, which is almost half. And I found that to be a really startling statistic as someone who is still just in training and hasn't even entered practice yet. We also showed really high rates of burnout, which you can see along the x-axis there, as well as really low rates of professional fulfillment, which is why we end up in kind of this sad spot down in the bottom right corner of this chart. And so I think from a systems perspective, in a time of shortages in anesthesiologists and anesthesia providers more generally, I think not only adding trainees and adding to our workforce, but actually retaining people in our workforce is going to be really, really important. And so we need to understand, why do people want to leave practice? Why do we have such low professional fulfillment? And why are there so many people struggling with burnout? So if we go a little further and we talk a little bit more specifically about the system level and about residents, when we look from a patient safety perspective, amongst resident physicians, burnout and depression have been associated with self-reported suboptimal patient care and increased medication errors. And so we often know that self-reported studies are not the most valid, and sometimes people are not great at estimating. But I think the fact that people are able to recognize that they're providing worse care and having more medical errors says a lot. And so we also know that burnout is associated with lower patient satisfaction. Now, research has shown that program directors from across Canada agree that resident wellness directly affects patient health and well-being, which I think is kind of underscored by the previous study I talked about. And so at a system level, burnout is also associated with reduced physician productivity, increased physician turnover, and increased physician cost. So this really highlights to me that burnout doesn't just affect the person experiencing, but also it negatively impacts patient care as well as physician professionalism. So now that we've kind of talked about what burnout is and why I think it's so important, I wanted to talk about some of the recent trends we've seen in wellness and in burnout. So data from the American Society of Anesthesiologists shows that the rate of high risk of burnout in March of 2020, so this is really at the start of COVID, not even taking into account the pandemic we all went through, but the rate of people at high risk was 59.2%, and the rate of people experiencing diagnosable burnout syndrome was 13.8%. And so at that time, emotional exhaustion was experienced by 53% of respondents, depersonalization was experienced by 37.2%, and reduced feelings of personal accomplishment were experienced by 25.9%. So that's a lot of people experiencing these symptoms. Other studies show that the rate of burnout syndrome among anesthesiologists ranges anywhere from 10 to 41%. And I think noteworthy is the fact that anesthesiologists practicing in the intensive care setting appear to have the highest rates of burnout, with rates close to 55%. So when we look more specifically at Saskatchewan, there was some excellent research done here in the department, which found that in 2021, 67% of residents, family practice anesthesiologists, and staff anesthesiologists express low professional fulfillment. And there's this really great quote, which is that compared with work before the pandemic, only 1/3 reported they enjoy work just as much, and few reported that morale was high where they work. And also noteworthy was the fact that within the past 3 months, 6% of respondents reported making a major medical error that could have resulted in patient harm. And so I think it's interesting to see just actually what we're dealing with here at the U of S. And I would be curious to even see what it's like the further we got into the pandemic. So we've talked about the high rates of burnout and low professional fulfillment even here in our own province. And I think it's worth talking about, why are we so uniquely at risk? Why are we so disproportionately affected? And I guess that begs the question, why does it matter why we're at risk? And to me, if we know what the risk factors are, then I think that guides us to where we can best intervene to either mitigate or ideally eliminate or address some of these issues. So I think it's worth talking about some of the individual factors. I'm not going to spend a lot of time on this. I think given what we know about burnout, the fact that it occurs primarily in the workplace, spending a lot of time harping on individual factors that can predispose someone to burnout is probably not where we're going to get the most bang for our buck. But we know that being female, being younger age, having a family, which I think can often lead to this conflict that they talk about between work and home, such as missing meal times, family activities, and time with our spouses or partners, um, is a big one. There are some specific personality traits such as neuroticism or anxiety, and then being earlier in your training. And they talk about in the literature this idea of a survivor effect. So consistently, we see that late career physicians report less burnout. And one explanation for that is this idea of a survivor effect, which suggests that those who are most burned out may be more likely to leave practice earlier in their careers. And so the only people really left behind are those who either suffer less from burnout or who have developed ways to cope with this stress. And so again, I think from a workforce retention perspective, I think it's really important that we try and mitigate some of these risk factors. So moving on from individual risk factors, and I guess, sorry, I don't know if I can go back, but I guess one thing that's noteworthy is that those individual risk factors aren't just seen in our specialty, those are seen across medical specialties in almost every field. So moving on to workplace factors, there's a number of risk factors that I think are really commonly seen in our practice, which is obviously high stress environments, long work hours or working greater than 40 hours a week, are really associated with burnout risk. And in particular, according to the Ontario Medical Association, a report that they generated, the risk of burnout was actually found to increase by 3% for each additional hour physicians spend working per week, by up to 9% for each additional night or weekend physicians spend on call, and by 2% for each additional hour per week physicians spend working at home. So I think that really highlights how much of an impact the amount of time we actually spend working can have on our risk of burnout or our risk for developing burnout syndrome. Other things that obviously in the workplace can have an impact are things like staffing shortages, limited support at work, isolation in the workplace, lack of enduring patient-physician relationships, negative coping strategies such as substance abuse, or reduced autonomy in the workplace. So what about trainees? So compared to medical students or those who completed postgraduate training, rates of burnout during anesthesia residency are higher. And this is, again, a trend that's been seen across multiple medical specialties. Residents experience some of the highest rates of being at risk for burnout and also experiencing true burnout syndrome. I think one point that was noteworthy to talk about, and this was mentioned in the literature, but this is also, I think, a conversation I feel like I've had with other residents, with staff physicians, is as one of the quote unquote road specialties. So that's radiology, ophthalmology, anesthesia, and dermatology. Anesthesia historically has often been considered to be one of the least demanding medical specialties. And I think a lot of us here would kind of laugh at that or probably respectfully disagree. But I think as a result of this perception, it seems that the stress of a career in anesthesia is often greatly underestimated, particularly amongst medical students and as a result, new trainees. And so I think there is a concern that this lack of understanding about the actual stresses that a career in anesthesia brings might leave people quite shocked and ill prepared for the rigor of training and eventually practice. And I think that can, in and of itself, contribute to some of the burnout we see. Other factors that can affect residents are things like fatigue, stressful work situations, high financial debt loads, again, that conflict between work and home. And I think for a lot of residents, not for everyone, but for a lot of residents, residency is our first real job and the first time we have to navigate working a really demanding career with our home life and how do we navigate that workplace. And a lot of us enter residency, I think, a lot later than some of our peers would enter their first real job. And so I think that can also contribute. Things like unclear job expectations, exam pressures, and overall career uncertainty are also factors. So we've talked a lot about the problem. I think now we need to kind of talk about some of the solutions. So what can we do? So again, I'm not going to spend a ton of time on individual interventions, but I think it is worth talking about a little bit. So we know that things such as regular exercise, healthy diet, and resilience are key. And resilience, I think, is something that, again, like burnout, is tossed around so much that it's one of those things where I find you have a general sense of it, but there is actually a definition, which is it's the ability to bounce back or recover from stress. And I found it interesting that there is evidence that self-administered online interventions based on increasing pleasure, engagement, meaning, positive relationships, and accomplishment can actually increase well-being and reduce symptoms of depression or burnout. And so there is a role actually for training resilience. And I think we often view it as something that people either inherently have or do not have. And that just doesn't seem to be true based on the evidence. I think mindfulness is another one that we talk a lot about. And so the way I saw mindfulness defined and the definition that I really liked was that it's paying attention in a particular way, on purpose, in the present moment, and non-judgmentally. And so again, there's evidence that mindfulness-based interventions are linked to better clinical outcomes, including improvements in anxiety, depression, and self-compassion. And mindfulness-based stress reduction interventions are noted to be effective for reducing the negative psychological effects of the work environment. So again, there is some more information there. And I think it goes without saying, there's undoubtedly a role for individual interventions as listed above, but I do think that given that burnout is recognized to be associated with the workplace environment, I think the most bang for our buck undoubtedly comes from system-based interventions. So the majority of published studies have investigated the treatment of burnout using those individual approaches I previously touched on, including exercise, meditation, resilience training, or the use of specific coping mechanisms. And unfortunately, there continues to be a lack of literature on the prevention and treatment of burnout using system-based approaches. There's more. I think it's increasing. I think people are increasingly recognizing the importance of this. But compared to data on individual interventions, there's quite a bit less. What is notable, however, is that system-based interventions are associated with higher treatment effects compared with physician-directed interventions. So again, I think this speaks to the importance of looking to make these systemic changes. Particularly, system-based interventions that combine multiple elements such as structural changes, improving healthcare team communication, and instilling senses of teamwork and job control are the most effective in reducing burnout amongst physicians. So the first one I wanted to talk about is this meta-analysis. And so a little bit of background on this is that the Accreditation Council for Graduate Medical Education, or the ACGME, which is based out of the US, attempted to address resident burnout by launching the Physician Wellbeing Initiative, which provides resources for the graduate medical education community that are intended to promote well-being, mitigate the effects of stress, and prevent burnout. And so this meta-analysis by Vasquez et al. Found that most programs that were successful in reducing burnout incorporated multiple teaching methods and were most often serial programs that occurred during a predetermined amount of time during trainees' protected education time as part of their residency. And so programs that used a wide variety of training facilitators, including residence program directors, yoga instructors, psychologists, and professional coaches, were also found to be the most effective. And this is just an infographic kind of from that research study that talks about what successful interventions were composed of and what they did. And so they suggest that it's possible that incorporating training programs within protected academic time, such as part of the academic half day, lectures, or scheduled wellness days, could effectively reduce burnout. And they were really clear that incorporating additional responsibility for residents, so having wellness modules that have to be completed on their own time, is actually more harmful than helpful and could actually act as a barrier to prolonged change in physician burnout levels when some of the well-known contributing factors to burnout are excessive administrative tasks and long work hours. So they were really, really clear that this is something that needs to be integrated into the workday, and is not something that should be thought of as a one-off, module that we have people complete at the start of residency and kind of, never talk about it again. So again, of note, unsuccessful programs or programs where they didn't see a reduction in burnout, or in some programs where they actually saw an increase in rates of burnout amongst trainees, typically used two or fewer teaching methods and didn't use serial programs. So they kind of did just treat it as a checkbox, did a wellness presentation and kind of moved on. So moving on, I think this is an interesting point when we talk about why do we have so many interventions targeted at trainees. So this study by Carmel et al. Found that when we compare more compassionate or empathic physicians to others, this group tends to be younger, earlier into practice, and scores higher on pro-social, non-stereotypic attitudes and empathy measures. But they also have increased rates of emotional exhaustion. And so I think this highlights that the same personality traits and coping strategies that we can probably all agree make someone a quote unquote good physician are also the same personality traits that put them at greater risk of burnout. And the fact that younger physicians seem to follow this kind of more idealistic approach, and a compassionate, empathic attitude might also be a contributing factor to why they're more exposed to burnout risk or more at risk of burnout than older physicians. And so I think this, combined with the high rates of burnout we see amongst trainees, again highlights the importance of intervening at the trainee level stage. And I'm not just saying that because I am one. So we've talked a lot about trainees and residents. And I think it's important to also talk about interventions for staff physicians. And so I think what was a little bit disappointing to me is that there are much fewer burnout prevention strategies targeted at physicians who are finished with training. I think it makes sense given some of the data we've just talked about and the changes in rates of burnout as we progress throughout a medical career. But it is disappointing to see that there's not nearly as much kind of efforts overall made for people who are done training. So this was a study by Panagiotis et al. And what they found was that organization-directed interventions are more likely to lead to reductions in burnout. And again, this fits with the data we've already talked about. And again, interventions that combine several elements, so structural changes, fostering communication, and cultivating a sense of teamwork and job control tended to be the most effective. And again, physician-led interventions led to very small, significant reductions in burnout. What's interesting is that such intense organization-directed interventions are pretty rare and they're not evaluated really widely. And the majority of organization-directed interventions that were included in this meta-analysis introduced really simple reductions in the workload or made really simple schedule changes. And I think a lot of the concern about making some of these changes or making more wide sweeping changes is really concerns about how these things will actually be implemented and the possible delivery costs of these interventions. So again, I think all of this really points to the fact that organizational directed interventions are really key. And I think this goes back to where burnout arises from, which is in the workplace. So in 2019, the Ontario Medical Association established a burnout task force. And a key objective of this task force was to determine the causes of and potential for solutions to physician burnout. They made a number of recommendations, which can really be summarized into their 5 key solutions. And that's number 1, streamline and reduce required documentation and administrative work. Number 2, ensure fair and equitable compensation for all work done. And then number 3, I'm going to talk about this a little bit more, which is increase work-life balance by making organizational policy changes. So they suggested things like normalizing flexible work arrangements for physicians, including options for part-time work, job sharing, float pools. And these float pools I had to dig a little bit more into is basically providing coverage for people to attend to life events. And they felt that overall, having a little bit more control over one's schedule obviously fosters some autonomy within the job, the lack of which has been associated with burnout. They also talked about enhancing supports for medical student and resident work-life balance. So this can include duty hour maximums below the regulated maximum. So things such as having, a maximum of a 16-hour call shift, which is something we obviously have here at our institution. And then they also talked about the importance of exposing residents and even medical students to some of the administrative burden associated with a specialty before they choose a specialty. And they thought that this can be they recognize that this can be kind of challenging. But I think going back to that point I made about anesthesia being kind of seen as a less demanding medical specialty or a more lifestyle friendly medical specialty, I think it's important that we make trainees and medical students aware of just what they're getting into before they're, thrown into the deep end on these things. The other thing they talked about when we talk about increasing work-life balance was this idea of time banking. And this was actually something that's done at Stanford. And faculty are basically given credits for time that they spend on unpaid or under-recognized responsibilities. So things such as providing clinical coverage on short notice, serving on a committee, etc. And they could redeem this time banking for things of their choosing. And so it was often determined by a department. But basically they were credits. And so these credits could be redeemed for things such as hiring a house cleaner, getting meal delivery, getting assistance with grant writing, or lab management services. And I thought this was really unique and quite an interesting idea to have this kind of time banking that you could redeem not just for something at work, but something that might benefit you in your personal life. When we talk about number 4, so promoting seamless integration of digital health tools into physician workflows, I'm not going to touch too much on that. But I do want to talk about the 5th point there, which is providing institutional supports for physician wellness. So they talk about obviously encouraging and supporting a workplace culture that prioritizes and promotes physician wellness. So I think culture can be kind of a nebulous and intangible factor to understand and influence. But there are some concrete steps that we can take to improve it. So in particular, they specify that our workplaces should be adopting explicit principles for a workplace culture that prioritizes and promotes wellness. And they really touch on the fact that leaders in our departments are looked to model and normalize behaviors within their workplaces, including those related to not just the actual jobs we do, but related to self-care. So things like modeling well-being, sharing vulnerabilities, encouraging self-care, and identifying and advocating for needed support goes a long way from our leaders. And I think we're really lucky in our department that I think our leaders do a really excellent job of that. They also talked about the importance of regularly evaluating the levels of physician burnout within a department, and then making sure that the results of those surveys are, number 1, anonymous, but number 2, actually shared within the department. And that, I think, again, helps with transparency, which can contribute again to an improved sense of workplace culture. I think acknowledging, if a department has an issue, is half the battle, right? We can only start to fix things if we know that there's a problem. And so I think that really goes a long way in fostering a sense of accountability within a department. And then finally, again, touching on those individual interventions, if needed, organizations should coordinate and implement proven individual level interventions for physicians. So I wanted to talk a little bit about some of the interventions that have been put into place here at the U of S specifically. And there's an excellent article I'm happy to send any of the references to people, but it was done here in the department. And so they developed an anesthesiology resident wellness program at the U of S in July 2010. And this was informed by the 8 domains of wellness. I'm not going to list them all, but also 4 pillars of a healthy workplace. And what they found was they did a survey of the residents, and I think the results really speak for themselves. 75% of residents agreed or strongly agreed that the residency wellness program had been a valuable experience, and 86% felt that the topics were really relevant. 71% felt that the information and skills they learned were applicable in their work, and 68% felt that that was applicable in their daily life. And so the most valuable components that residents cited were things like team building activities, mentorship and orientation for the first and second year residents, and resident wellness nights. So I could talk about this all day as a member of our wellness committee, but I think I'd rather just show you some photos of kind of what we get up to here in the department for anyone who's not really intimately familiar. So we do a number of things year after year. We have barbecues, we have kind of wellness nights, we have wellness days kind of baked into our academic half-day schedule. We have a wellness retreat. There's a number of activities that go on. And so I think these just highlight a few of those things. In the top left, I think that's actually my cohort out bowling with our academic advisors. In the center top, there is a barbecue that I think happened last year. At the top right, I think it was Dr. Larson had coordinated kind of a plant making, I think those are succulents. The bottom right, we have a new newsletter that we've started putting out as the Residency Wellness Committee to kind of keep people informed of what we actually do as a committee. And so that has been circulated amongst the residents, and I think will be circulating within the department sometime soon. In the bottom center there, we have Dr. Kaczynski putting together our amazing call room, which is, I think, maybe the nicest in the hospital, but I know I'm always happy when I head up there. And then in the bottom left, I think that's Dr. Lund and Dr. Brittany Benson ordering a meal. And I think all of these things just really go to highlight that I'm not going to say that our department is perfect or without any flaws, but I think we on the whole do a really excellent job. I think it's really obvious that people in this department care about each other, care about each other's well-being. And I think that's something really worth highlighting. So one thing I do want to talk about, and I think that's becoming a little bit more prevalent, not so much in the literature, but I think is becoming more of a topic of conversation, is when we talk about wellness and we talk about spending time on it, I think there is sometimes a question that's asked, which is, has the pendulum swung too far the other way? Have we prioritized wellness too much at the cost of maybe not prioritizing our training? And so I think the question I then wonder is, how do we balance training and job readiness with wellness? So I came across this article, and this is by a physician named Dr. Rosenbaum, who is a cardiologist. And she discusses a dynamic that appears to be on the rise in all levels of medical education, which is that once routine aspects of medical education or training are now being deemed potentially harmful. And in particular, she notes that encroachments on time away from the hospital, such as reading at home or staying late to deal with evolving illness in a patient, are often deemed threats to mental health. She goes on to note that in medicine, where we're obviously currently kind of balancing a crisis in well-being with the requisite rigors of training and workplace demands, she wants to debunk this belief that one's mental, physical, and spiritual health is the responsibility of the organization, which is to say that Dr. Rosenbaum feels that our training programs and our workplaces are ultimately not responsible for our well-being. And she has this really excellent quote, and this is from one of the leaders actually of the Black Lives Matter movements. And they basically say, discomfort is part of the human condition and a prerequisite for learning. Violence and oppression are to be avoided, but not discomfort. And the ability to discern the difference is a form of emotional maturity that we should encourage. And I think it's obvious that we work and learn in an imperfect system, but I think it's speaking with people who've come through this system before me. It's pretty clear that efforts have been made, and I would argue are continuing to be made to improve our educational and training system. I think this is a tricky issue, though, as obviously maintaining a commitment to excellence while also remedying failures in our system requires us to make this distinguishment between unnecessary harms and the necessary discomforts that Dr. Rosenbaum speaks about. And I think that begs the question, which is, why is it so hard to do this? So Dr. Rosenbaum talks about this really interesting idea of a new social hierarchy. Um, and what she kind of puts forward is this idea that in the traditional social hierarchy in medicine, we really rewarded people with the intellectual and social fortitude to manage really, sick patients and really critical medical issues and really difficult situations. And she now puts forward this idea that in the new social hierarchy, high status is actually afforded to people who speak about the ways in which residency demands, such as long call shifts, a high volume of admissions, or other workplace tasks, are not just exhausting, but are actually considered to be unjust or injurious. And so she goes on to actually quote a senior resident she spoke with who really struggled with this change in culture within medicine. And this resident actually said, it becomes unconscionable not to comply because then you are considered to be oppressing them. And she was talking about some of the people who really speak out about how unjust or injurious some of these expectations are. And so I think in order to understand the implications this cultural shift can have within the field of medicine, we actually need to look through a wider cultural lens at why grievance now carries such power. And so I read through a number of different articles on this, and I will openly admit I went down quite the rabbit hole, kind of getting into this. But what I came across this quote that really stuck out to me. And in an article by the New Yorker book critic, Parul Sehgal, called The Case Against the Trauma Plot, she asked this really important question, which is, in a world infatuated with victimhood, has trauma emerged as a passport to status? And is it our red badge of courage? And she basically argues that in a push to advocate for wellness and normalize trauma, we have now, in fact, elevated trauma from a sign of a moral defect to instead a source of moral authority. And so I want to be really clear. There are times, obviously, where grievance carries moral authority because it should. Things like racism and misogyny have been really longstanding issues in medicine, and recognizing the immorality of both the structures and the people perpetuating things like racism and misogyny is long overdue. But I think, as I mentioned earlier, when I was talking about why anesthesiologists are so susceptible to burnout, understanding the issues we're facing are really critical to solving them. And so I think the concern that Dr. Rosenbaum puts forward is that when we label every bad or uncomfortable feeling as quote unquote trauma, it can lead to problems distinguishing among harms of varying magnitudes, and it can make it more challenging to actually target interventions towards the issues that really need them. And so, building on that, I think when we make these conflations, so conflating things like experiencing daily racism, which is obviously hugely traumatic and I think would undoubtedly cause moral injury, with things like, having to stay late to admit a patient that came in right before the end of shift, which, can be referred to as quote unquote traumatic. It can make it really challenging to enforce rigorous clinical standards because doing so can come across as insensitive or uncaring towards someone's trauma. And so I think Rosenbaum makes this really interesting argument, and I'm almost inclined to agree, that treating all uncomfortable situations as trauma or moral injury might threaten our clinical competence and our training. And so she asks this really great question, which is, does the pursuit of excellence conflict with the pursuit of well-being? And spoiler alert, I do not have an answer for this question, but I think it's a question worth asking. So I came across this podcast episode, and this was actually recommended to me by someone I really respect. And I would encourage all of you to take a listen. It's a really excellent conversation. It gave me lots to consider, and it's actually what inspired me to look more into this issue and ultimately was the inspiration for this entire talk. And so this podcast episode came out after Dr. Rosenbaum's paper that I just mentioned, and it was born out of her gaining access to a listserv that was circulating among medical educators in the United States. And for those of you who don't know, because I didn't, I had to Google this. A listserv is basically like a big email chain that's going around. And so this particular listserv was focused on medical students' requests for wellness days. And Dr. Rosenbaum talks really openly that in her previous reporting, she's heard many stories from educators describing how hard it's become to enforce educational norms that could be construed as threats to well-being. And some of the fears she talked about were that educators fear losing jobs, being quote unquote canceled, seeming old or out of touch, or being perceived as uncaring about trainees. And she said that they often fear being accused of trainee mistreatment. But even more than that, these educators really fear even talking about this issue for all of the reasons I just mentioned. And so she had a really hard time actually getting someone willing to speak on the record about this, but she was able to get one physician who is Dr. Amy Holthauser. And Dr. Holthauser is a professor of pediatrics and a former vice dean at the University of Louisville School of Medicine. And so Dr. Holthauser kind of starts off this conversation with the idea that the way we frame our conversation around this matters. And she said that she personally felt and was really disappointed that as soon as this topic is brought up, people kind of frame it around the idea that educators or people in positions of authority don't care about the well-being of medical students or medical residents. And she felt that was just completely the opposite. And I think, based on my personal experience, I think it's really clear that, at least within our department, the people who are in these leadership roles are not doing it because they don't care. They're doing it precisely because they do care and they're really passionate about it. And so I think the way we frame the conversation is important. So Dr. Holthauser makes a number of great points. I'm going to try and summarize it. Like I said, it's a great episode and I would recommend you all just go listen to it, but I'll do my best to summarize some of these points. But Dr. Holthauser makes a really great point pretty early into the conversation, which is that these medical students she was dealing with make a request for wellness days, but there's actually no evidence that interventions like wellness days make any difference in wellness or burnout scores. And actually of note is the fact that satisfaction scores make minimal changes when we're given things such as wellness days. These changes in satisfaction scores typically only last 1 year. And then she found in her experience that since it's taken for granted by the year below, who've never had it a different way, that new demands are just put in place year after year. And so because this is a podcast, Dr. Holthauser didn't cite any specific research, but I went and I looked into this, and I was really actually quite surprised to find that reduced work hours in internal medicine and orthopedic surgery residents didn't show any significant effect on burnout rates. And a study of protected sleep time for internal medicine interns similarly did not demonstrate any effect on depression, burnout, or empathy. And I was really surprised by that because I think those are some of the things, we often think will make this big impact, and the data just doesn't bear that out. And so Dr. Holthauser went on to say, it's not that there's any single wish list item for students or for wellness that's in and by itself triggering a concern. It's that there's an awful lot of creep going on. And I think the point she's getting at is not, what will our medical training system look like in a year from now or even 2 years from now, but if we have this slow erosion, what is it going to look like 10 years from now or 20 years from now? There's also evidence that despite all these measures that are supposed to support well-being, and I think we would, in turn think would support students' academic progress, it's number one, not helping well-being, but students are actually doing worse academically year over year since a lot of these things have been implemented. And since 2020 alone, trainees in the United States have seen their step one scores drop from a 97% pass rate to 90%. And that's kind of sequentially decreased year after year. And so she has this really excellent quote, which she says, "It feels like we're doing cognitive behavioral therapy for a broken leg. It might be fixing something, but it's not fixing the problem." So that brings me to my next point, which is kind of, sorry, where am I here? So This quote is from Dr. Holthauser, and she said, "And so I care about you, and I lovingly decline to do it." And she talks about what she thinks the actual problem is. And in Dr. Holthauser's opinion, she sees the problem as there is a lack of kind of love for learning that's permeating within the medical profession. And then she also talks about, again, this lack of understanding from the trainee side about the love that educators and teacher clinicians have for their students and their trainees. And she said this quote really highlights that because she said this in response to these medical trainees asking for increased wellness days. And she really compared it to being a parent, and she is the parent of two teenagers. And she kind of described it as similar to when she coped with her teenagers and feeling like you're struggling to bridge a gap where these teens understand that you care deeply about them. And so the way you're showing that you care is not by giving them what they want, but by making sure they're prepared, that they have what they need, that you are entrusting and empowering them to grow through uncomfortable times. And she further goes on to really say that, good parents allow their children to struggle at the developmental level that's appropriate for them, and good teachers need to do the same for their pupils. And so I think with the idea of kind of this struggle in our training and the uncomfortable feeling that can arise from that, it brings us back to this question, which is, does the pursuit of excellence conflict with the pursuit of well-being? I think it doesn't. I think that, as Dr. Holthauser highlighted, providing a framework for some healthy struggle and providing support for people kind of working through the struggle doesn't mean that wellness is unimportant or that educators don't care about their students. And I think, from Dr. Holthauser and Dr. Rosenbaum's conversation, they both talk about it as educators, that they feel in their experience making things easier for students has made them less well, more helpless, less confident in their abilities, and less capable. And that ultimately, by making things easier and focusing more just on wellness, it's actually having a paradoxical effect in that it's decreasing people's well-being, and it's also not training people to be good doctors, which in and of itself doesn't feel good either. So I think that educators have probably shied away from these discussions for a lot of the reasons I talked about earlier, for fear of seeming out of touch, for fear of being quote unquote canceled, for fear of seeming uncaring. And I think inevitably when topics like this get brought up, or when educators or people in positions of power bring these issues up, there is often this perception that people think, oh, you don't care about trainee mental health, or are you even aware of the suicide rates within our profession? And I don't think that's necessarily a fair angle to take. I think we need to discuss these topics. And I think, like I said earlier, I think part of the way that we can show that we care about trainees, and part of the way we can show that we care about the next generation of physicians is by showing that we want to see them thrive, not just at the training stage that they're at, but throughout their careers. And I think a huge part of doing that is not just promoting wellness through wellness days off or time off, but actually making sure people are prepared for the rigors of a career in medicine. So I have more questions that I don't have the answers to, but I think in order to begin to answer these questions, we have to at least be willing to ask. And so I want to leave you with all of these questions that I've been sitting with for a while. But how much well-being or wellness are we entitled to? At what cost? And ultimately, who decides? So I want to thank you all for taking the time to listen. This last section, I understand, was maybe a bit more of a hot button issue, and it definitely is less evidence-based. There's not a lot of research or literature on that, and I recognize that, but I'm hopeful that we can have a nice discussion. I'm happy to answer any questions, and I'm really excited to hear everyone's thoughts. Thank you so much.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.